California. So we have two locations for a lot of patients who are inquiring. Our main location here is in Michigan, Bloomfield Hills, Michigan, which is one of the northern suburbs of Detroit. And then also Northridge, California, which is one of the northern suburbs of Los Angeles. It's a pleasure and an honor to be discussing another Facebook, YouTube, TikTok, and Instagram Live. And I want to go ahead and recap. It was a wonderful experience to be in California last week, where I will say that I was blessed to have what was the best team that I could have between the anesthesiologist, Dr. Gadi, who was very seasoned and basically experienced, and his expertise provided what was the best of the care. The facility in itself, what is a Medicare approved facility, state of the art, and a very nice facility. And also my nursing staff, my surgical assist, my surgical tech, and my entire team that was present. So I'm blessed to have had that. I want to go ahead and address now what is a series of like couple, 2, 3, 4 reviews that have come forth that are kind of expressing what I would say suboptimal experience. I want to go ahead and take this opportunity by saying, and this is collectively, let's say over the last 4 to 6 weeks, the feedback that I have gotten from my patients. Now, first and foremost, we're truly blessed to be offering the surgery in a very safe, confident, reliable, reproducible way, such that when the patients do get done, they truly have had their best experience possible. That is, the entirety of the implant capsule, all inflamed tissue has been removed in a very defined, direct way. And this is where my patients have basically that physical evidence and proof, be it from the videos and the pictures, exactly what happened during the surgery, as if they were inside the operating room, directly watching the videos all the way up into the upper part of the chest. This is where you will see majority of the surgeons remove the entire implant capsule. Directly what is visible, but going into the upper part of the chest, the capsules are left behind, unfortunately. So I just reviewed an op note where the surgeon went through the nipple areola and did what is a subtotal capsulectomy, and I will tell you it is impossible to operate from a small incision, i.e. around the nipple areola, and remove the whole capsule. And this is unfortunately, even the many surgeons who are making the cut up and down and fixated on the lift, the capsules are not being removed completely. And just like we heard from our guest, the plastic surgeon, the surgeons remove as much as they can, and then leave the drain behind, leave the capsule behind. And unfortunately, the patient does not get the right and the complete surgery. In my practice, all patients get that 100-100-0 rule. That is 100% of the time, with 0% of the capsule remaining behind. And that is the essence. Now, in my practice, let me go ahead and address a few concerns. There are patients in the last 4 to 6 weeks that I've managed had that clot issue, and this is where the patient had the neck manipulation and clots in the upper, the carotid dissection. This is a significant finding where the patient has a vascular surgeon, and I made a specific video pertaining to that. There is a patient of mine who's basically wrote a comment in regards to the pain issues. No HIPAA violation here. It turns out that she's now getting 4 very exaggerated high intense dose where Dilaudid is 10 times more potent than morphine. And this is, I as a plastic surgeon would dare not even think about writing those medications, that amount, because these are very dangerous medications. To compound medications such as a narcotic, which in itself gets people high and affects the central nervous system. If you add muscle relaxant to this regimen or this cocktail, there have been reports by other surgeons where the patients have fallen down, lost consciousness, they felt lightheaded, it was too much, it causes respiratory depression. So this is where I want to do a safe practice. Now, ultimately, if you look at the feedback that I'm getting, certainly from the patient, but more importantly from the primary care doctor, that primary care doctor needs to tell me as a surgeon that this patient is going to have pain issues. So just this week alone here in Michigan, I operated on a patient who had a pain doctor who wrote for the pain medications, extremely high levels of pain medications that were being prescribed to this patient. And I told the patient, I'm not a pain specialist. I do not want to give you pain meds. And the next thing you know, you get up in the middle of the night at 2 a.m. And you pass out, or you trip and fall because you are loopy or lightheaded. Or if you add to this cocktail, for example, a muscle relaxant, that certainly will do it, because that in itself combined together may have this additive effect. I want to practice safe medicine. I have always practiced safe medicine. I rely on my primary care doctors to give me that concrete information. I rely on the primary care doctor to tell me that this one patient has 4 psychiatrists, or has had 4 psychiatrists that have managed this patient's underlying anxiety/chronic issues. This patient needs to have alerted me herself and inform me, so that I would have been able to talk to the psychiatrist and say, what is it that we can do so that we make sure that this patient gets the best experience post-op possible. I want to practice safe medicine. Now, in regards to, say, for example, the tier 1 or the tier 2 or the tier 3, there are patients that I've operated on where if you look at the amount of contouring that was done and the amount of that pseudo-lift skin that was removed is more than the volume of the implant. And this is where the patient has a capsular contracture, significant bottoming out and lateralization of the breast implant, double bubble deformity. This is a big part of the surgery, is to do the surgery in itself, where the implant capsule is removed, be it 100% total capsulectomy or the end block. But a big part of that surgery is the contouring, and the patients know this, right? Remember, you go to another surgeon and they do a lift, you get charged so much more. In this case, this is that pseudo lift that I'm talking about. This will encompass that 6 hours, 7 hours that I've spent in the operating room, for some patients 5.5 hours. And just like anesthesia gets billed extra per hour and with whatever increments, there is certainly not only the intensity of the surgery, but also the length of the surgery. So if a patient gets a 4-hour surgery, that's very different compared to a tier 2 or tier 3. So for example, my mastectomy patients with the extensive alloderm, or a mastectomy patient automatically qualifies into what is a tier 2 category. Now, if they have a lot of extensive alloderm, they have a mass, they have a fluid, or they have what are large implants above 500, automatically per contract, this should not come as a surprise or news to the patients. You're automatically going to the next level up, and this is very clearly established, laid out, so there's no surprises. In my practice, I am very transparent, very direct, playing and by the book. And if we ever look back, I would not have done anything differently for any of my patients that have discharged myself from the recovery area. And I've handpicked the best team. Yes, they may have a stutter. You cannot make fun of my nurse because she has a stutter or she has a broken English. Guess what? She was the best 30-year-old experienced seasoned nurse from the operating room. And I would love to have her as my nurse if I was going to have surgery. So you cannot criticize my nurse's English, for example, because she's the best of the best and handpicked. I'm very blessed to have her, and I even reached out to her so that she can offer her expertise and her wisdom and the care that she provided to all my patients in California. So going back to the point, we are a very transparent practice. We want to help. We are one team on the same page. If there is a discrepancy between your primary care doctor, who happens to be a PA that day, who quickly filled out the form because there was no thought process in this, you were at a disservice because that quality of care was not provided by your team. If your doctor was a covering doctor who did not know you well, or was a new established primary care doctor who did not let me know about your extensive 15-year psych history where you have been on multiple meds, or another patient who has been on chronic pain medication usage and 4 milligrams of the Dilaudid every 4 hours is what it takes for that patient to feel that pain control. I dare not write that amount of pain med because I do not want to cause harm and hurt. And this is where your primary care doctor has to step up and say, you know what, we mean well, we want to discuss with you so that we establish the best post-op course. I want to go ahead and say this very carefully. The best intraoperative course and best post-operative course is the best preoperative course. This is where I myself, before the surgery, indulged, obsessed with your chart. Not only I, but my anesthesia team member, so that we have looked through your chart and we are going to provide you the 110% exceptional care that each and every single patient deserves. So that when you get done with the surgery, you will state that you got what you signed up for. You got those pictures and high definition videos, which is that only one bond that you have, that your surgeon did the right surgery, the correct surgery. Yes, it took that 5.5, 6.5, 7.5 hours, but it was done such that my time got compensated, the facility fee compensated, the length of time that it took. The pre-operative discussions are integral for a best intraoperative and post-operative outcome. Just right now, I reviewed a case on a patient who has active breast cancer. I declined her surgery automatically. She has to get clearance from her doctor, and we need to get that clearance and the green light so that as I proceed with surgery, I know the patient is going to be taken care of. What if she has stage 4 disease with metastases to the brain? I do not want to be operating on someone who has this potential illness. I do not want to be, one day I canceled the case with a patient who came all the way from Texas, and she was sitting on my desk, and she was sitting on my chair and pre-op, and she was on the paperwork was on my desk, and I reviewed her and I examined her and I said, we have to cancel your case because what I see on paper is not what I see on the chart. Another patient has not seen a doctor for 20 years, went into an urgent care, got a quick in and out 15-minute clearance. I declined to operate on that patient, and I said we need to do better than that. And this is where the responsibility of the patient comes in, and very importantly, the responsibility of the physician comes in, who's giving the clearance and that confidence that as I do proceed with surgery, I know this patient is not going to have muscle relaxant problems. This patient is not going to have pain issues. This patient is not going to have psychiatric issues post-op because of the severe anxiety because it has been submanaged. This patient is not going to have wheezing because she took her asthma medications despite it having prednisone, which is going to cause weight gain. And this is where we want to mention to you as you sign up with the tiers. We went in on a patient who said that she has 425 cc implants, and it turns out she had not only saline but 685 ruptured silicone implants. Automatically, she was taken up to a tier 3 level because she had ruptured implants, she had 685 above 500, and she had what was a mass. Automatically, that's a tier 3 level. This is no surprise. The patient happily paid for this. This patient went in and said she had no alloderm. It turns out she had extensive amounts of alloderm, more than what anyone would have in a natural given surgery, and she did not even know. Just the fact that she had extensive alloderm, automatically, she's a mastectomy patient, she's in tier 2. Alloderm, size of the implant, length of the time of the surgery puts her in tier 3 category, and this is very transparent, very appropriate, and very direct. I share with you exactly what happened before, during, after, and I will say this as I conclude. I couldn't be happier with my staff, from my surgical tech to my first assist to my nurses to my handpicked anesthesia team. We're providing exceptional quality care, which we all the patients know. We're not about deleting texts or deleting reviews. We are proud of our reviews. That one patient who's going to write that I had this issue, you have to go back and explain why that issue even occurred. So you're not going to make that next patient more anxious by not completely discussing and revealing what the facts were going into your case for that one patient. And this is where it's an honor for me to discuss and be very transparent, not only about this, and I can individually discuss. So this one patient, for example, who's written this review, I've already talked to her 6 times, in addition to the one time post-op where I couldn't talk anymore. And the point here is, I'm here from the beginning to the very end, so that if I do decide to operate on you, I will, and my entire team will give 110%, so that when you look back at it, you got the best experience as a patient, the safest experience as a patient, complete transparency and complete integrity as far as when it comes to the delivery of care that every patient deserves, no matter who you are, what age you are, so that when you get done, you have the peace of mind, you got that informed consent. So with that, I'll end. Please take care, and I'll be more than happy to answer any questions if anyone does have. This is Dr. Khan.